We're going to spend the rest of our time talking about how do we help the patient preoperatively and what should we be doing for the patient postoperatively to optimize their outcomes. So let's think first about the patient who is scheduled for ostomy surgery and what their concerns are, what their fears are. What are the critical interventions for that patient? What should you make sure happens for that patient in order to give them the best outcomes possible? So if you're the one interacting with the patient preoperatively, there are critical things for you to assess. There's critical information for you to provide, and you want to make sure that that patient's stomach gets marked. So let's talk first about, well, what are the things you should be assessing and creating a plan to take care of this patient long term? So you certainly want to look at the patient from the perspective of, can he, can she provide self-care? Or do they have issues that might impact on their ability to provide self-care? So let's talk first about physical issues. What if when you're talking to the patient you notice that they have severe rheumatoid arthritis with marked deformities of the fingers? You already know they're going to have a very hard time. They're probably not going to be able to cut out an opening. So you're thinking, oh, I've got to modify their equipment. I need to put them in a moldable system or in a pre-cut system. Are they going to be able to manipulate a closure mechanism, or do I need to think about whether or not they're a candidate for a closed-in pouch? What if the patient's had a CVA? What if they have a spinal cord injury? So you've got to see, what's their hand-eye coordination, how much dexterity do they have? Can they manipulate a pouching system? Can they manipulate the closure? You might need to involve occupational therapy to help you come up with a system that enables the patient to do self-care. So they can be extremely helpful to you and to the patient. So look first at my ability to perform self-care from a physical perspective, which comes down very much to hand strength, hand-eye coordination, and mobility. Then look at me from a cognitive perspective. Am I going to be able to learn the basics of my care, or are you going to need to involve someone else? What if I seem to have a really hard time understanding your explanations of the surgical procedure? You're watching my face. You're asking me questions. After you give me information, you're going to ask questions to see, did I understand? Pay attention to, are there family members with them? Who's their support system? That's going to be critical as well. Many of our patients are elderly. Some of them are in their 80s or 90s. They might be overwhelmed. Pay attention to their ability to handle information, to process information. You want to pay attention to psychosocial issues. So again, I pay a lot of attention when I'm seeing a patient preoperatively. Are they there by themselves? Is there anybody with them? Is the person with them supportive and engaged, or are they on their cell phone with their back turned? I'll ask a patient, do you live alone? Who's going to be available to help you? Do you have people you can call? You want to know how much support that patient's going to have. You also want to be aware of their openness to support groups. Would you be interested in talking to someone who has an ostomy? Would you be interested in some online resources where you could connect with other people? Very helpful to know about financial concerns. What if your patient has no third-party coverage? They're self-pay, but they're indigent. Then you've got to factor that in when you consider products. You want to simplify their pouching system. You want to keep it as low cost as possible. You're probably going to need to see if you can get them hooked up with an indigent care system or an indigent care program. Most of the major manufacturers have indigent care programs. And then other issues. What if there are cultural issues or religious concerns? I'll give you some examples. In some Arab cultures, they have a clean hand and a dirty hand. And typically the right hand is the clean hand, and that's the hand you use for social interaction, for shaking someone's hand, is the hand you use for feeding, for eating, drinking. And the left hand is the dirty hand, and that's used for elimination, you know, for wiping yourself after you go to the bathroom. It's very hard for them to do two-handed ostomy care. Most of our ostomy care involves both hands because this hand is supposed to stay clean. So you would want to talk to that patient and say, if you wear gloves, could you use both hands? Or do we need to look at finding a way for you to do all of this one-handed? One of my friends was from Detroit, and she was in home health, and she worked with patients who came from many diverse ethnic, religious, cultural backgrounds. And she said, you know, one of the things she learned to do was say to patients, I know you're from a different culture than me. I don't want to do anything that offends you or makes you uncomfortable. So please tell me if there's something I need to know. And if I start to do anything or I start to say anything and it's uncomfortable for you, please stop me. And if you give that patient permission up front, then they can say to you, you know, that's not going to work for me. I can't do that. Or can we find another way to do this? Same thing in terms of involving other family members. That's very much cultural as to who can be involved in their care. So talk openly to patients about their concerns, about things you might need to address to make this ostomy care as comfortable as possible. And that's a good way to say it. Look, having an ostomy is a huge adjustment. And it requires you to learn things and master skills you didn't have to do before. And it's impacted by your culture, by your religion. So let's talk through what you're going to need to do, and let's identify anything that could be a barrier and see what we need to do to overcome that barrier. Also very helpful to know about their medical surgical history. It gives you some insight into how they might view this ostomy. If I've had a long-standing history of inflammatory bowel disease and I've been very sick, this ostomy might be seen much more positively than if I have a new diagnosis, or if I've been diagnosed with cancer and this becomes the symbol of my cancers. You kind of have to put everything together, walk in that door with the mindset of I'm going to learn as much as possible about this person, and my focus is identifying things that I should address to make this as easy as possible. So now let's talk about what you need to share with that patient. So you're getting information from the patient, information you need to put together an appropriate management plan. Now you want to share information the patient needs. Your goal is that the patient knows exactly what is being planned in terms of surgery, knows the basics of what's involved with an ostomy, gets a chance to answer their questions. So you want to be sure that the patient understands why surgery is being done and what's being done. So a common approach is to say to the patient, okay, I'm one of the nurses on the ostomy care team. I'll be working with you post-operatively. I wanted to get a chance to talk to you before surgery to find out what you already know and to answer any questions you have. So why don't we start with you tell me what you already know about what's going to be done and why. And then I listen. And that tells me what they know and what they don't know. It allows me to identify gaps. So sometimes my patients will be very well informed and they'll say, well, I know I have bladder cancer and they're going to have to take out my bladder and they're going to do something for urine to get out of the body, but I'm not quite sure what. Sometimes my patients are really vague. I don't know I think there's a tumor there somewhere. They're going to try to get the tumor out, get all the cancer out. I'm not sure exactly what that means and what they might do. Whatever they tell me back, that gives me my starting point for filling in gaps and making sure they understand what's going to be done. There's a lot of gaps that occur because the surgeon talked to them and they were under a lot of stress. So I started out when I was first doing ostomy care thinking that the surgeon had not done a very good job explaining the surgery to be done. And then I came to realize it had nothing to do with that. The surgeon had been very thorough, but I started hearing patients say things like, you know, after he told me I had cancer, I think I don't know, I must have blanked out because I can't remember much of what he said after that point. That's why preoperative discussions are so critically important. So they might have been given the information before, doesn't mean that they retained it. So you're going to walk them through what's being done, why, answering questions they have, use diagrams, they're extremely helpful. Then once I make sure that they know that their surgery involves taking out the bladder, taking out this section of bowel, and that they're going to have the bowel connected to the skin and stool or urine is going to be coming out through that opening, then I want to spend some time on the basics of ostomy management. That's usually their next question. Well, how do people live like that? How am I going to manage? So first we walk through what's going to be done. Then I literally show them a picture of a stoma so that they know what it's going to look like. Then I show them a pouch and show them how it attaches to their abdomen and how it's emptied and talk about usual frequency of pouch change. And we reassure them that the ostomy care team will be working with them post-operatively to teach them the things they need to know before they go home. I want them to have the mindset that there are critical skills they will need to learn. Now, some patients are very involved in the preoperative session. They ask a lot of questions. They're like, well, you know, now how often did you say you have to change it, and does it ever come loose, and what would I do if it came loose? And, well, I'm going to have urine coming out here. How often am I going to have to empty that? A lot of people have lots of questions, and other people are so overwhelmed they can't even think what to ask. So what are the critical things to share? What's going to be done? Why? What the stoma looks like? The basics of management. You're going to wear this pouch. It's odor-proof. You're going to empty it when it's half full. You're going to change it a couple of times a week, and you're going to have help after surgery. So don't worry about learning all this. Just know there's a whole team who will be helping you after surgery. I find it very helpful to go on and mention to the patient, this is a lot. This is a big operation. It's a big adjustment. No one wants to have their plumbing rerouted. No one. And even though it's important, and even though it can be life-saving, it's still an adjustment. So give yourself time and give yourself permission. Give yourself permission to be angry. Give yourself permission to be sad. All of that is normal. It does get better, but the first few weeks and months are very challenging. That's when you're trying to learn everything, you're trying to get comfortable with it, and you're trying to come to terms with what happened. You definitely want to give time for the patient to ask questions, so I try to cover the basics and then say, what are your questions? What's running through your head? When you think about having this done, what worries you the most? And if they have a family member sitting there, I want to say, what questions do you have? Sometimes their questions are different. So you want to give time for both of them. Okay, so we're still talking about pre-op education. Now, the things on this slide, you might be covering this as a member of the ostomy care team other nurses on the team might be covering this. You want them to know kind of what to expect post-operatively. Some people like a lot of details. Some people are like, you know what, I don't want to know that much. You can tell me about it. Just tell me that you'll take care of me post-operatively and that you'll tell me when it's time for me to learn something. But you want them to know, okay, you're going to have an incision. Here's where it's going to be. You want them to know that they're going to have drains, they're going to have IV fluids. You want them to know how pain will be managed. That's probably one of their biggest concerns. A lot of patients will ask, what about pain management? Is there a pain team? Am I going to have to ask for pain medication? Will you give it to me routinely? How does that work? Helpful to tell them that even though the day of surgery and the day after surgery, they probably will just want to stay in bed, that we'll be getting them up and helping them move around because that's critical to rapid healing and to optimal recovery. If they're having, whether they're having intestinal or urinary diversion, it's going to affect the bowel. So you want to say initially you'll be either not getting anything by mouth or getting just liquids, but we'll gradually advance your diet as your bowel starts to work. Sometimes you're able to eat by day 3, sometimes by day 4, sometimes by day 2. It depends on your bowel. That's actually a huge factor in time frame for recovery. How long does it take for the bowel to begin working again? And as you know, it's extremely variable. So you say to the patient, right at first you'll be on IV fluids, you might be getting some liquids. How fast we advance your diet is dependent on your bowel.